So I sent out an email maybe 15 minutes ago that has some resources in it. I wanted to get these to you before the meeting. They're not necessarily something you're going to use within this meeting, but they're kind of topics that we're going to address during this and our December meetings. There's a few things that are specifically going to support this type of work. There's the measure investigation tool. There's kind of a data hygiene calendar, those type of things kind of tied directly to what Leah's going to talk about today. And then the other worksheets are more of um, let's think about what we've done and what we want to do. Let's organize our thoughts around what our activities are going to be and kind of set the stage for where we want to go. What what I experienced when I was in the health center in quality is probably very similar to what you're experiencing. You have your ideas of what you're going to do. You think you have an idea of how it's going to go, and you get about 3 or 4 months in, and you look at this list that you made, and there's no way. It's like crumple it up, throw it in the trash, try again next year. And so what I'd like to help support you guys do this year is have a plan and keep it a little more front of mind while still being very flexible because we know we never know what is going to pop up. So that's kind of what the rest of those are for. You guys have your quality plans, you guys have your internal cadence, but this is just to bring a little bit more planning to it. And what I'm hoping to do in our 2026 meetings is within our hour meeting spend some time on data hygiene sort of things because those seem to be the things that get squeezed off of our calendar. It's very easy to look at the little fires that are popping up and let the data hygiene piece kind of sit until it becomes a disaster. So I'm hoping that by using some of our hour every month to do some of that, it'll help you keep ahead of things and not have as many fires to put out. So Leah is back. I had several people reach out and ask when Leah was going to finish her session that we started last month at the Azara training. And so we fit her into the quality form, and it looks like everybody except Diana has a Zara. Diana, we're going to be talking about a population health tool focus, but it still is very pertinent to everything that's going on in your EHR. The kind of the focus is looking at what our data is doing, where our data is going, how are we keeping track of our data? Because regardless of what tool we're using, whether it's an EHR, whether it is a Zara, whether it is an Excel spreadsheet, what we need to keep in mind is our data is only reportable if it's in a place that the computer can read it. And things can get sideways when we have updates or we have workflow changes or we have template changes or we have staff turnover. So as we talk a little bit about this in kind of the Azara lens, this is very applicable for ECW, for NextGen, for Athena, because that is actually where all of the data that Azara uses to report on comes from. So they tie very closely together. And what's what you're actually doing when you're doing data validation or data audits in Azara is you're actually auditing your EHR because that's where the data is. And then figuring out where the glitch is. Is the glitch that somebody doesn't understand the report? Is the glitch that the workflow's not being followed and so the data is not in a reportable field, that type of thing. So, Leah, if you want to go ahead and get started, we'll kick it off. I really want you guys to be feel very free to ask questions, ask for examples. If you have something going on in your health center that is challenging to you, please bring it up. We have some time cushion today that we can absolutely do that. If you're where you cannot come off of mute, go ahead and put it into the chat and we have people watching the chat and we'll get those pulled out as well. So, Leah?
Okay, perfect. Give me 1 second as I get my computer set up here. All right, almost there. Okay. All right, so last time I joined the meeting, we focused a lot about the data in drives and how it comes in from the EHR into drives. It goes through our connectors, it's updated. And so that gave us a really good foundation for then what, right? What do you do in order to keep that data healthy and clean? And I think that's where we kind of ran out of a little bit of time. So I had to go quickly through some of this next topic that I'm going to re-review today. And so we're going to talk about data hygiene and how that equates to quality improvement. Um, Data hygiene is all about understanding your data. Where is it documented? How is it flowing into the system? Is that accurate? Are we missing workflows, etc.? This is important because if you don't understand that key piece, developing your quality goals is really, really difficult to do because the data may not accurately represent what is actually happening in your organization. And so you need to have clean and accurate data in order for you to do any work from a quality improvement perspective. So when we think about kind of the approaches that you can take to data hygiene, there are really three different ways to think about it. The first is you're in drives, you see something look wrong. Maybe your alert is firing, but the patient, actually has a colonoscopy on file, or a depression screen was done, but that patient, when you do go to do validation, is not in the numerator. So when you find errors like that, the first thing you want to do is kind of put out that fire. And that we'll kind of investigate here today, but it's really about seeing something that's wrong, investigating why it's wrong, and making a correction to fix that piece of data that's coming in an inaccurate way or missing. The second approach is really about trying to identify patterns in data issues. And so, is there one provider that we're seeing have really, really low performance on a particular measure? Maybe it's just a documentation thing. Maybe they're not documenting it in a way that we have told drives to look for. Or maybe, maybe it is they're not, that one provider's not performing the screening and you need to, it's more of an education thing. So that's kind of that second bucket, is identifying those patterns, right? Is a certain provider or a certain care team member that is either documenting incorrectly or in a place that we don't know, Azara doesn't know where to look. The third bucket is all about prevention, preventing those fires from happening in the first place. And that is all about being proactive in updating your mappings and drives, dependent on workflows, changes into workflows, new templates in the EHR. So anytime those things occur at your center, your next step when you're setting those things up or, creating that new workflow or template or whatever it might be, that you're proactively going into drives and updating those mappings or reaching out to our support team to make sure that they update the mappings. So that's kind of the three approaches to think about. You're going to hear me talk about data hygiene and data validation. Data hygiene is your system, right? That's the processes and routines that you do on a monthly basis. And I believe in your packet, there is a data hygiene calendar that Heather sent out to you. That's an example of like data hygiene, right? Like you've set up a calendar of those things that you want to review on a monthly basis. Data validation is the tools and activities that you use for investigating the data and then comparing it to the EHR. So you, as part of your data hygiene program, you want to do data validation, but there are also other things that you might want to do as part of your data hygiene program that are not data validation. And so when we start to think about what's wrong with my data, they typically fall into three buckets. One is that data from the EHR isn't showing up in drives. Why might that be? One is like the timing of how everything works. The data in the EHR is not immediately available in drives, and not every page is updated every day. So, an example of this is a patient came in yesterday and got an A1C. That A1C result has been posted to the EHR yesterday, let's say. It was a point of care test. It was in the EHR yesterday. Your clinical data in your EHR, so the PVP or a registry, um, would update that would have updated overnight, and that data would be available that the A1C was completed. So that if that patient came back in today, the alert wouldn't fire on the PVP. If you ran a registry on that patient today, you would see their most recent A1C, which was taken yesterday. You would see that value in your registry. However, measures process over the weekend only. And so scorecards and dashboards are um, are based on measures. And so measures, scorecards, and dashboards only update over the weekend. And so that same patient who had their A1C done yesterday, it it was a weekend. Let's pretend it's not the weekend. Let's pretend today's Wednesday. They came in Tuesday, had the A1C. You would not see the patient in the numerator of the measure until over the next weekend, until the following Monday. And so when you're doing data validation, this is very important because if you're validating certain patients and you're seeing, oh wait, they're in the EHR that they had their A1C, but they're not in the numerator of the measure, please think about the data timing and was that A1C done during this week? And if so, on the following Monday, the patient will be in the numerator. Any questions on that? The other piece is missing data. Drives will only get data from where you've told it to look. And so if there's a scanned medical record or a new clinic location or a new LOINC code that you're using, and you've never let that know, let drives know that that's something to look for, we won't know to look for it. And so it needs to get mapped in order for us to be able to pull it in. And then finally, something that is unmapped. So a lot of the challenge around here is for things like colonoscopies or um, mammograms where the files come back or the results come back in a PDF or a fax or something like that, and it has to be like named. The naming convention matters because every time you name it, if you're completely changing the name, it would be like a new item that we would need to go and look for. And so having a consistent naming convention for those results is really important. And that can be also done in the mapping admin to map those results. I'm going to do a little tour of the mapping admin and show you how to use it and kind of how to do these some of these things. So the mapping admin is really the back end part of drives. There are certain categories in which you can map as a self-service offering, you can do it. And then there are other categories like qualifying encounters, labs, and immunizations, those three that you would need to, you can view your mappings, but you would need to enter a support ticket to make any changes. And here's just a handy um, kind of cheat sheet about which sections of the mapping admin impact mostly your UDS tables. One of the places that we see in your mapping admin for overdue mappings that, need to be evaluated, structured clinical data is definitely the number one. And then patient interactions and face-to-face qualifying encounters. Those are the other two. But structured clinical data is where we'll focus a lot of our efforts here today. And then these are the view only. The other thing I'll make a note on the mapping admin, codified data is typically pretty easy for us to grab. Most of those codes, like qualifying encounter codes or LOINC codes, diagnosis codes, things like that, they're pretty standard from organization to organization. We know the code, so we're looking for it. Structured clinical data is a place there's a lot of variability. Structured clinical data is a drop-down menu, a checkbox, things like that that aren't codified. And organization, health center to health center, this is extremely variable. And this is where we need your help to know what to do with that structured data, right? There's not like a secret, there's nothing in the structured data that's going to tell us where to put it. That needs to be kind of a manual process. So one thing to do when you're in your monthly kind of routine for your data hygiene program would be to visit your mapping admin once a month and review unmapped values. Archive the things that you don't care about, that you won't need to use, and map the ones to the appropriate drives bucket. And so I encourage you all to follow along in your own mapping admin. If you have that available, log into Drives, go to your mapping admin, and then we're going to just use the example of structured clinical data to look for unmapped values right now. So if you have it available, please follow along. So when you visit the mapping admin, and I believe I did a tutorial on the mapping admin last time. I'll try to do a similar review as we go. But you're in your mapping admin. Just to orient on how the mapping admin works is that when you log in to the mapping admin, you're going to see mapped drives values. These, when you click on this, right, this will default to this. It's going to highlight blue. This indicates this list of 54 are all the categories that are available in drives to which you have already mapped something. When you click on something in this section, so right now I've clicked on unmapped, that is what populates the right-hand side, the right-hand side of this, of the chart here. And so what this is going to give me are those 52 instances of what is in the unmapped category. This is what you should be reviewing on a monthly basis. Come into unmapped and you can see what you have unmapped. For example, I see a prepare screen here. This I think I have a next screenshot, but I would map that to the SDOH prepare assessment recorded. I think I just went through here. The other, this piece here, if you were to select, so if you can recall, this is automatically selected if you were to click on drives values with 0 count. This is going to give you all the drives categories that you could map to. However, currently you do not have anything mapped. And so an example of where this might happen is you are doing some validation, and we're going to walk through those steps in a moment on a CQM. And you notice that there's in the value set, there's you know, a category of structured clinical data for SDOH screen, say. Um, and you come into and when you look at this, you're in this is highlighted, and you might hover over this word here and search for SDOH, and you don't see anything pulling up. That means you don't currently have anything mapped to SDOH. And so I would come over here, click on this, hover over mapped drives value, hover over to get the 3 lines, click on them, and then type in SDOH to see what options are available that I could potentially map things to. How is this landing? Is everyone tracking with me? And if not, please, like this took me, honestly, someone explaining it multiple times for this to all click, and a lot of just going in and clicking around and playing and seeing how it all kind of ties together and works. So I get that it's not extremely intuitive. Okay, if anyone has any questions as we go, just please let me know. All right, so back to the workflow of coming in and identifying your unmapped values. And Heather, if there are I'm kind of keeping going, but if there are questions in the chat, please just stop me and ask them out.
Hey, there is a question that Dylan just sent that says he sees alcohol use. I see alcohol use days 12 months is not mapped. It's part of the craft screening. If craft isn't mapped, do they submit a ticket with a screenshot?
So let me give me 1 second. What I'm going to do is I'm going to jump into demo because that might be a helpful exercise. Um, I believe you could probably map it yourself. I think we have some sort of like, hold on, like a generic alcohol screening category, but I'm not 100% sure. I'm going to come into demo, share my screen, and we'll kind of navigate this together just to see how I would investigate this. So I'm going to come into the mapping admin. I'm going to go to structured clinical data. And I'm assuming, right, we're going to pretend that there's something unmapped here. And you're saying it was craft, 12-month alcohol use days, 12 months. Let me see. I'm going to look at this and see what it says. Oh, okay. So that's actually a category. I'm sorry, I misunderstood the question. So you have a category here that there is nothing mapped to. So we're coming into here and we're seeing okay, so maybe it is mapped in this version. Let's see. Here it is. And in your version, there's nothing mapped to this. So what I would do is I would go to if you have any unmapped values, I would look and see if any of the unmapped are in fact that alcohol screening that you have. And you could map it to that. You could map it to that if you see it there. The other place to look would be your archive, because perhaps someone at some point saw that come across the mapping admin and were like, you know what, we don't need that. We're not going to worry about it right now. So I would go into archive and see if I could find, that question coming in. If I did, I would, instead of it, I would take it from archive and I would edit and I would put it to, what was that? Alcohol use days, 12 months. And that's how you would map that. If what I just said, you don't see anything in unmapped, or if you don't see anything in your archive, then yes, a screenshot, a support ticket would be the next step. And if you could provide a screenshot of where that screener is being completed and a patient example, then our support team could get that mapped for you. Dylan, did that answer your question? Okay. Yeah, okay. So, come back. Are there any other questions related kind of to the mapping admin and looking for unmapped values? I think I went through this already. The one thing that I didn't mention is that you're in the right-hand side. So I'm gonna this side here, right? You see these counts. These are the number of patient examples this raw EHR value is being pulled in from. And so you can see for the screen, the prepare screens, there's almost 1,400 patients who have a prepare screen that Drives isn't doing anything with. And so that kind of gives you the magnitude, right? If you came in here and there's a count of one, I might be less concerned because it's not something that people are doing very often. However, if there's a lot and it's something that impacts a measure or something that you use within Drives, then that's, what I would prioritize for taking action on. The other things just to keep top of mind for your data hygiene program is that any changes to practice operations could potentially impact mapping. And so anytime you have new providers or locations, the new providers will come into your provider admin. However, their service line and service category needs to be defined. Same thing if you have a new location, that should just flow in from your EHR. However, you got to check on it and make sure that it's there. And, potentially, if not, that would be a support ticket. Any new lines of service, changes in your lab. So if you start using a new lab or doing a new test, that would absolutely be a support ticket. If you go to your lab mappings and you don't see it there, support would have to add that for it.
Leah, I want to add something here with the labs. As you guys have your interfaces with your different labs and everything, sometimes those codes or those labs that you're ordering can change. And one thing that can throw off reports in your EHR and in Azara is if those don't have the LOINC, LOINC code attached to them. If you have updates or changes to your immunizations, those should have an immunization code as well. And if those fields are not filled with the correct code, those aren't going to show up on your report anywhere because those are code-based items, and that's what the the EHR and Azara are looking for. So that's just one thing that sometimes that's what the issue is. And it's one of those on the back end in the weeds sort of things that sometimes gets overlooked. So just wanted to call out that anytime that you have any changes in your labs or you're ordering new things, make sure that the code is associated appropriately to that because it's going to not be recognized in any of the reporting if that code isn't on that particular item. So I just wanted to, that had come up earlier this year, and so I just wanted to highlight that specific thing.
Thank you. Yeah, it is important because we, again, only know what you kind of tell us. And so we do have some AI running in the background for LOINC codes specifically, where if we do get labs that, we're not sure of the LOINC code or it's not there, we do try through AI to assign a LOINC code, but sometimes we don't have the, kind of supporting data to know where to put it. If it's something that's, seen across our database as, this lab is this LOINC, we would go ahead and auto map it with the AI, kind of recommending that action. But we have a lot of unmapped lab values and we can't do it for everything. So if there's ever something that you're seeing, it's definitely worth a support ticket anyway, just to let them know that, there's this new LOINC code that you're using or a new lab that you're using, so they can go ahead and map it. Okay. So the next thing we're going to do is do some validation. This is something that we recommend. This would be a measure validation. This is something that we recommend happening at least once a year for your measures. Our recommendation is to not wait until, November, December, January, and then try to do all your UDS measures, get them validated in that short period of time. The best approach really is to set yourself a schedule for the entire year where you do review on an ongoing basis of, maybe pick a measure or two a month. That way, you know that attention has been put to it, and the hope is that come UDS season, when you're preparing for reporting, you're not going to have to spend a ton of time validating, because you've done it on an ongoing basis throughout the year. I know that's, a lofty goal because sometimes, when it's not necessary to do it, the other things take priority, but it does make your UDS kind of validation and submission process a lot smoother when you're doing this work throughout the year instead of waiting until now. So from a very high level, how we approach validation are these 6 steps. So understanding the measure definition, evaluating trends in data, trying to identify non-compliant patients and then understand, are they non-compliant because we didn't do something? Is it a true non-compliance or is it a data discrepancy? And maybe it was put in the EHR someplace that we haven't told drives to look. Then you review the values that are mapped, explore things that might be unmapped, and then if there's anything unmapped that you can't map yourself, that's when you would reach out to support to have that value mapped. I'm just going to poke into the chat real quick because I saw a couple things. Okay. Dylan's question, you've changed the mappings a couple of times. Everything is back where it was.
I went through and updated, so I went through the unmapped and I just went through and almost all of them but one actually I could map to another category. And then I exited the mapping administration, came back to the mapping administration, and then it reset. So all the things that I did just map are unmapped again.
Hmm. Give me one. That should not be happening. So let me just sorry, I am just going to come back into my demo environment. I should probably just share my whole screen so I don't have to stop sharing. I'll do that. So we'll just pretend this was unmapped. You've come in, hit this icon and mapped it here. And
Yep.
then you're saying, okay, this was what I just wanted to make sure that you took the appropriate steps. So you've mapped it and then you came back in. If you wouldn't mind, I think a support ticket on that would be the next best course of action, because that's not the way it's supposed to work. If you take action and added it to a certain category, it's supposed to stick there. And so there might be a bug or something in the system that caused it. I'm not sure, but you could submit a support ticket to investigate. Sorry, I can't
Okay.
be more helpful on that one.
Will do.
All right. Now I should just be able. So now do you all back to see my slideshow?
Yes.
Okay, perfect. Thanks, Trish. All right, so now let's think about measure validation. We're going to use colorectal cancer screening as the example. And the very first thing you want to understand is the measure itself. What are the specs of the measure? What gets patients into the numerator, the denominator? All of these things matter when you're doing validation. And so where you can find that is you would click on the info snippet, which is the little I next to the title of the measure name. And you would start to understand, okay, so who are patients in the numerator and the denominator? I usually start with denominator first. So we're looking for patients 46 to 75 years old that have had a qualifying encounter during the measurement period. So that's important to note, because the measure will default to trailing year, but if you were to be looking just at a month, you have to remember that the measure would only pull in patients who had a visit that month. So just, keep that in mind. The numerator for this measure is looking at any of these different screenings for colorectal cancer. And then depending on the type of screening, we look back different amounts of years because of the guidance on, how these screenings are used. So for example, if you are getting a FIT, it needs to be done once a year. If you're getting a FIT DNA, it has to be done every 2 years, or a colonoscopy is every 10 years. So we have the logic built into those measures. If they had a colonoscopy, that's good for 10 years. If they had a FIT, we'll keep that. That would be good for 1 year. So that's already built in. You don't have to worry about that. The thing you want to understand is what are the specific codes that we're looking for. And you can do that in the value set. Typically, as I mentioned, right, the structured clinical data is where we tend to see the most variation. And so that would be a great place to start when you're doing validation. So I would hover over where it says code system. I would select structured clinical data. For this measure, the structured clinical data includes these 4 items. Plus, and that's for the numerator. There's also exclusion, right? Hospice care, long-term care, palliative care, etc. So that's why these are pulling in, because that would be the exclusions to the measure, and they're powered by structured clinical data. So you'll want to look at all of the structured clinical data that is associated with this measure in your mapping admin. So like we're going to put a pin in that. We'll come back to that in just a moment. So the next step is to start to understand measure trends because this helps point you in the right direction. Do we have a data problem or do we have a workflow problem, right? Are people just not ordering a cancer screen, or are the cancer screenings getting completed and for whatever reason not pulling into drives? And that's what the question that we're coming back to and trying to answer. So what I'm noticing here is that my measure performance is starting to trend down, right? Um, this again is trailing year. What I might do now is look month over month. So I would go to the month view because month views, it's smaller amount of data broken up into each month. It's sometimes easier to see changes more easily when we're looking at that small amount of data because calendar year and trailing year adds patients to the numerator and denominator every month. And so it smooths out the trend line. It's not always easy to see changes. So it's one of the ways to kind of dig in is to change it to the month view. You could group it by provider to start to see, okay, this teal color down here, is that just really low performance or are they documenting in rogue places that we don't know about or Drives doesn't know about? Then you want to try as best as possible to find patients who are non-compliant. And you want to understand what that non-compliance is caused by. Is it actual non-compliance or is it a data discrepancy, a data issue? One of the ways we suggest trying to tease that out is this idea of a model patient. A model patient are going to be patients who have just one care gap, right? And the reason we use this is because and typically the patient that we use as a model patient is sex at birth female and age greater or equal to 50. Typically, if this patient has had their breast cancer screening done, their cervical cancer screening done, their A1Cs done, right? Like they would be more likely to have their colorectal cancer screening done as well. That's kind of the rationale, right? Someone who has multiple, right? They've come into the center, they're getting regular care, they're doing all their other screenings. Like this gives us the best chance of finding that patient who, for whatever reason, their data is not coming through that the colorectal cancer screen was completed. So what you can do here is create a scorecard. Let me see if I have that on the next step. Let me go to the UDS scorecard to show you how this works. So you could use a UDS scorecard or you could create a scorecard with a smaller number of measures. But what I'm going to do is I'm going to come to care gaps. We're going to look for patients who have one gap. What's happening? There we go. Oops. We're going to go to all. We're going to do greater than or equal to 1. Something weird is happening here. Anyway, it should work that it would change all of this to one. I apologize. Sometimes demo's funny or there's something going on here. You just, we'll pretend that I filtered to one. And then we're going to look, again, you would go to demographics and you would go female. And we're going to do age greater than or equal to 50. Yeah, we'll pretend again, something's happened to my demo that this isn't working. Hopefully it's all working for you. So we'll pretend that that's 50. And then we would come over to colorectal cancer and we put gap. So essentially we filtered down to women over 50 who have their other gaps filled, right? They've done all their other screenings, but they only have the colorectal cancer screening gap. And then I would start to validate, right? Then you would start to look up these patients on the list here and see if they have a record of a cancer screen in their EHR. So it's a great way to target a population who you would think be more likely to have their cancer screening completed, given that they have all of their other screenings completed. Any questions on using a model patient to find patients in the care gap? Has anyone tried this before? Okay.
Well, and while they're thinking, one of the things that Dylan said was that toggling between the rendering and usual provider, try that in your scorecard, and you can apply a filter for primary care provider first, so the data isn't thrown by same day or other service line, especially when doing trends. And so I would think this would be particularly applicable if you have like an urgent care setting. And so a patient's acute care, they're not necessarily maybe going to be addressing some of those gaps. But in their primary care, like wellness visits or follow-up visits, they should be. And so thank you for that tip, Dylan.
Yeah, that's a good point. Okay, so we've, done some validation through finding those patient examples. The next step is to go I'm taking the pin out of those structured clinical data items that we found way back here, these four. And we're going to look in the mapping admin under structured clinical data to find, right? What I've done is I'm in the map drives value. I'm going to hover over that gray map drives value. And then I'm going to just start typing in col, right? I'll see the colectomy, the colonoscopy pull up. I'll select those off. And then I can start to see. I'm now clicked on colonoscopy. And these are the 16 places in the EHR where colonoscopies are documented. And so what you should be thinking about when you do that is, do I think that I've captured everything? Do I know of other places that people may be documenting that are not reflected here? And you can always click into these patient counts to see, to get an example of where that's documented. So I would click in to the patient count. I'd pull up that list and I would look in the EHR to see, where exactly is that. The second thing to do here is identify what is not mapped. And so here I would go to my unmapped category and I would hover over the source EHR box and start to type in colo, right? Because you can see completed order colonoscopy, colonoscopy, right? All of those things pull in. And so then you can, from here, right? These are all of those colonoscopies. You come in, hover over the word, and you map it to the colonoscopy. And then you repeat that process for these values below. And this is an example of how you do this with colorectal cancer screening, but really this can be done with all of your measures in the same format. And then connect with the support team if you can't figure it out. Okay. That was really all we wanted to cover today. Any questions on that validation process that we just went through? All right. Heather, anything else that you wanted me to cover while you have me that you think might be helpful?
That sounds great. Does anybody have any questions about any of the reports or validation in Azara? Anything that you're like, how do I do this? Or what should I do for this issue that I'm having? Any thoughts or questions on that? And feel free to go ahead and put those in the chat. And then I want to ask everybody, just as a curiosity on my part, were you able to, at any point in 2025, do data validation to see how a measure was working that wasn't because somebody said this report's broke? And we can put that in chat, or you can wonder if any of the reacts would work. Comparisons to EHR reports. Those are never going to be exact. Part of that reason is because, and especially I think this is true in ECWs, ECW looks for one place, and Maria, keep me honest here, I think it's very complicated to add additional sources for that data to pull onto the report. And Azara can map as many places that data might be stored in discrete data to be recognized as like numerator criteria, exclusion criteria, et cetera, et cetera. So they're not, I actually would be very surprised to ever see them exact. What I suggest is picking a number, like are you 3% and that's kind of a number I like. Are they within 3% of each other? And there's also one thing to keep in mind is that even if the data is exactly the same, the algorithm has to be written specific to the ECQM, but there's a little bit of difference between how each individual electronic reporting system writes that. And so they will never be exact. Large discrepancies trigger a review. Yes, that is one of the things I like about having the two systems as an option. Those of you with Azara have kind of a heads up if you're comparing your data in your EHR and in Azara, and it's like, we are off by 25%. What is going on? And then that triggers, like you said, an investigation to see what is not being recognized, which one is more accurate. And it's not always the higher number that's accurate. We would love for that to be the case. But, and I don't remember who I was discussing this with, but we were discussing, I believe it was tobacco status. And I believe they have, and if you're on the call, feel free to jump in and keep me honest. But I think we were talking about tobacco status and that it was in social history. And when the social history was brought forward, it was looking at it as if that had just been done, but it was bringing the history forward. So, you know, that may have been overrepresented in that report. Dylan, was that you that we were talking about? I hate to call you out. Okay, the more I talk, the more I thought about it. So that's just one example of where something could be off or recognized differently.
And then Heather, there
Mhm.
was I think if we're done with that topic, Maria had asked a question in the chat about the four-cut provider mapping area, and I'm happy to answer that. But I guess let's close this
Yeah,
question. If there's other things related to this, I'll
I
move on when
think
you're ready.
I think that closes out that topic. And then when you're finished with four-cut, can you talk a little bit about making provider groups?
Sure.
That might be something helpful instead of trying to do the filters all the time. Just put the group on.
Okay, so as I mentioned, as new providers are created in your EHR, they will flow in automatically to drives. If that is not the case and you don't see a new provider that you've added in the EHR, that would be a cause for a support ticket. When they come in, there's a couple different things. Like we're going to have your EHR service category. And then you can see, there's also has to be the UDS service category that you would map in the UDS service category mapping. But, you can see where that provider is assigned. You can see their active panel size. Whether or not they're active or deleted in the EHR, if they've had qualifying encounters in the past year. And here are two places where you can take some action. Include and filter would include them in the rendering and usual provider filters. So it clutters up your filter if you include, say unassigned provider or if you had old providers that don't have anyone on their panels, my recommendation is to remove those from the filter because you are not going to be filtering to those specific providers. The other checkbox is include in four-cut calculation. The four-cut calculation is part of our panel management suite of resources. It's an algorithm to provide a recommendation on who should be that patient's primary care provider based on their visit history in the past. And so we have some measures in drives related to four-cut, and there's also a filter in drives called the four-cut filter that will display data based on if the four-cut recommended provider was the PCP, this is what the data would look like. And so really in the four-cut, you only want to have primary care providers who you would assign a patient to as a primary care provider included in this being checked off on this page here. Questions, thoughts on this?
The one thing that I used to do when I was at a clinic level with this tool was that if we had a provider that left the organization halfway through the year, it defaults that it's going to remove that provider since they are now inactive from all of this. So if you want your provider to stay in the include and filter for, if you are filtering by, provider, if you have a provider pod that this provider used to be in or whatnot, you won't be able to pick them unless you go back in here and re-choose them to include in the filter. I didn't realize that, figure that out, 6 months before I left the clinic, but it really helped us. If you had a provider that like floated to multi-facilities or something like that, and you didn't want to use the facility filter, we would just go in here and re-include them in the filters.
And then from this page, you're also able to create a provider group. The provider group will show up in your rendering and usual provider filters at the very top. And so, for example, if you're looking and you only want to look at something for your medical providers, right? You don't want to include behavioral health. You can set up a group of your medical providers, or maybe you have different pods within your organization and you want to group, the pods together by the providers. You can do that with using this group, and it eliminates the need for every time you go to the rendering provider filter to select off like, 5 different people or whatever that might be. It just makes it one click and really easy. So you can create a provider group, a couple different ways. One, you can just click on this here, name your group, medical, well, and you can, double click or drag and drop or use these nifty little arrows to make your provider group. And that's it. And then you'd hit confirm. You could also just select them off here. And you could create a provider group, or you can add the selected to an existing provider group. So it makes it a little bit easier. The same is said for include and filter and include and forecut. This is relatively new in the last year and a half, where you have these bulk actions. So if you had a bunch of providers that, just joined or just left, or you needed to do something, you could just select them here and then include the selected in the filter, or remove, include in forecut, or remove. Any questions on this?
Is anybody using provider groups now?
I highly recommend it. Dylan, great. Yeah, it's a big time saver from then having to go in and click around and every time you go to a report to look at just the providers you want. Because those filters get pretty cluttered. And if you have like the referral management module, or if you're putting in a PCP like outside your organization, they all kind of flow into drives and it can get a little cluttered. And those filters can certainly get cluttered if you don't manage who is included in the filter.
One thing I will advise for those of you that are using or are going to start using that provider group is to make sure and note that on your keep track of things and check it periodically list, kind of like your data validation and stuff. Because when I left the clinic I was at, I had provider groups set up, and after a time, they were the providers that were on the list, some of them had left and new providers had joined, and so they weren't reflecting correctly. And I was still friends with a provider that's there, and she's like, I don't know what the problem is. That stupid thing doesn't work right. And I'm like, oh, yeah, I know what's going on with that. That's not what you think that is. And so as you name them, maybe put a name in that has a date so that if somebody were to be looking at it, they would see what it was, or have it on your list of things to check back in and review on, especially if there's always somebody different that's going to be working with the system. And how we sometimes make assumptions about what the reports mean, we can also sometimes make assumptions about what those filters and such mean. And so kind of learned that one the hard way. I kind of made a mess it when I left because I hadn't thought of that. So I don't see that anybody put anything in the chat from my question earlier. So let's see, I have some discussion questions here. Let me pull that back up. What is a success that you had in your health center? And it doesn't have to be Azara related, doesn't have to be HCCN related, but what is a success that you had in 2025 that you want to make sure continues in 2026? You put a process in place, you put a template in place, you put a something in place, you fixed a thing, you changed a workflow. What is something that you did that you want to continue in 2026? And when you think of that, put that on your list of things to do QA on in 2026. And that may be something you do monthly, quarterly, but put it on your QA list. Remember, quality assurance, you're checking to make sure the things that you have in place keep going. So that is one question. Let's see. CQM rounding with individual care teams. Ooh. Dylan, are you in a place that you can come off mute and tell us a little bit about that?
Yeah, so I think starting like fall of last year, so we've been doing about a year now. On a quarterly basis, we meet with each care team for about an hour, and we have like a rounding template where we ask like, what are the barriers? Do you validate? Take some time to validate with each care team how they're like documenting each CQM or like the priority CQMs um, that we have for that quarter. We look at their individual performance and seeing where it's headed and like what gaps are needed or um, if they're lower or higher on certain measures. And often it gives us like a little bit more, instead of having it at a big group meeting with all the people, like we can look at their particular workflows. And they'll be like, oh, I didn't realize like I was supposed to document it in this very specific way. We've been doing it, but we didn't document it here. So it gives a little bit more feedback, a little more personal, where that we get to walk with them through the process instead of on a big scale with everybody, like in a typical staff meeting.
Thank you. Do you find that you get more engagement in the small group?
Um, yes. Yeah.
Okay.
Yeah, because it is like well, I mean, we do get kind of like in the weeds, so we're asking the questions there, like show us, literally show us what you're doing. Um, um, so and then we can cover some of these other. We'll pull up Azara, pull up our dashboard, um, and look at some of the gaps, and maybe even pull up and say like, of these patients that are in this gap list, is there anybody that's sticking out? It was like they definitely should be counted. And sometimes they'll recognize the patients and be like, I know I documented that person or um,
Mhm.
that kind of thing. So it does give some more like personal feedback.
Thank you. Let's see. Alex, out from Genesis. You guys had new templates go in. That can be a big project. You're seeing some success from that. And if you're not in a place that you can answer, that is perfectly fine. Um,
Oh, I can answer. So, yeah, basically, we're starting to incorporate the Medicare annual wellness visits. Like we're trying to standardize it. So, yeah, we did create some templates as far as all the requirements and went through a list that's on a website that was very useful. Now, the next steps we're actually working on that we have projects to improve is time management. Just making it so that the we can get it to within like a 30-minute window, and the second part of that to accomplish that is creating kind of like a survey that the patients can take beforehand, a questionnaire, that's the word I'm looking for, a questionnaire that patients can take beforehand to answer a lot of the questions that are causing the time management issues. So hopefully that'll be accomplished within the next few weeks, and we can start adding these are so I'm working from home with my son, so apologize for the noise in the background, but yeah, so essentially we're trying to incorporate more of these visits because it's very beneficial for everybody involved, and it's a question of time management and question.
that sounds that sounds like a really big project that can have a whole lot of impact. I'll have to follow up with you in the future on that. Um, And Crystal, back to the basics. That is sometimes the hardest thing to do because that sometimes when we're trying to just make a little tweak here and there in in the standard daily day-to-day process, that can be really hard because you're changing muscle memory, you're changing habits, and sometimes that engagement can be hard. Does anybody have any suggestions on how to get back to the basics and pulling that PVP report? I know that some of you guys worked on that year, 18 months ago. Does anybody have any suggestions on that? Any thoughts on that? And Crystal, there is a report that we'll have to look at together that can help you track who is pulling that PVP and also how they are closing the alerts that can be closed during that visit. For example, you can run a report and see how well the depression screening alert is being, or depression screening measure is being closed and how well they're getting that at the PVP or at that visit where they pulled the PVP from. So does anybody have let's see, any thoughts on just tweaking that day-to-day process? And if you guys think of any suggestions or advice for other people on the call today or comments or questions that I've brought up, let me know. Shoot me an email because I would love to facilitate that exchange. Let's see. Leah, do you want to talk a little bit about the annual well visit for Medicare?
Sure, I can. Hold on. I'm so sorry. I just closed down my screen. I had it pulled up and then hold on. Give me 1 second and I'll get back there. But as I'm pulling it up so I can show you, there is a measure within Drives that you can use to track annual wellness visits. Let me share. I actually think it's Medicare. It's called Medicare Annual Well Visit. And this measure is looking for these specific codes that indicate a annual wellness visit. And the denominator is any patients with Medicare where is the primary payer. And there is a qualifying encounter in the last 2 years. They do have to have a Medicare policy number in the EHR for this one to work. So, if the data doesn't look right, it could be due, to something like that. But it is a great place to track whether or not you're doing annual wellness visits, and then you can always go into the detail list to find the gaps, and that would be patients in need of an annual wellness visit. We do also have a measure called Physicals Adults. And this is a little bit of a more broad measure that looks at the same thing. In this instance, we're looking just at patients greater than 18 with an encounter in the last 2 years. And we're looking for a physical exam code. The Medicare annual wellness visits also work here, but we broaden that definition of what the physical exam is in case, so you can use this measure for other populations, not just Medicare.
Leah, if they were, let's say, for example, they're working with Blue Cross and Blue Cross is giving them a target to reach for well visits for their adults. Can they do that with this report with the filter?
Well, if we had the roster, you could do it with the plan roster, right? That would be, you would see and I don't think we have that for Blue Cross right now. I think it's coming, but I don't think we currently have it set up. So you could do it with the plan. Otherwise, you could create a payer group and use the payer group to narrow the population. So in the detail list, right, you'll see primary payer. So you could get to it like this, right? That could be one way, but this is very dependent upon how you enter insurances into the EHR. And sometimes this is like a free text. And so you see BCBS in one, and then the next patient would be Blue Cross and Blue Shield. And each one of those is going to come up as a line item in the filter. And so another way that you could kind of create a group of all your Blue Cross, for example, would be to go into your payer admin, which is a new section of the tool this year. This is where you would update UDS financial class. Now, that used to be its own mapping category, but now you do that in your payer admin. And much in the same way, like you could create your payer group. So let's pretend we had BCBS, then Blue Cross and Blue Shield of Kansas, then Blue Cross and Blue Shield Kansas, like just a couple different versions. You could, let's say all of these were Blue Cross and Blue Shield, and then again, create a group. And then the group will live in the filter. I'm just going to go to this measure because it was right on top of, oh, sorry, I'm in the wrong measure. That's why that didn't work. Let's do this measure. And then we have primary payer groups. That's what you would want to use. And then that would limit to those who have this insurance listed in your EHR. I know I went way beyond what the question was, so I apologize, but I got excited.
Leah, they're used to me getting excited about it too. I tell them it's my favorite toy, but I think that's good information for them to have. Does anybody have I wish I could drill down to this XYZ in Azara?
Leah, you kind of gave me an idea there. And this is kind of drilling down, Heather. So if we all know, most of us probably have during the summer times, right? We have child visit events going on because you got to get the kid in for their school physical before they go to school. If you haven't tried this, regardless of how many people you do have percentage-wise on Medicare, if you've ever tried to do a Medicare physical day, whether that with like one of your providers or two of your providers, it actually can give you incentive credit based on how many you can get in and if you can get them in before like I think it's May or June, you even get double the incentive because it actually pays out more for a Medicare beneficiary to get their annual wellness visit done at the first half of the year than it does at the second half of the year. And so this would be actually a really cool tool to use because it doesn't really matter what Medicare Advantage plan they're on. Most all of them have that rule about how they're going to get more incentive. You're going to get more incentive if you have their annual wellness visit in the beginning of the year rather than the end of the year. And so that might be something you look at if you're doing something. I had not seen that measure. I kind of like it. So gives me ideas.
Yay.
I see Dylan put something about seeing if you could adjust for the refusals for immunizations. Does Azara Drives, does it pick up the refusal for vaccines, like if it's in a structured data or no? Is that not a part of that?
It does.
Okay.
if we can, if you can map it, if we um if it's done in structured data and like not in the notes somewhere.
That might be a little more complex than we can do in about 5 minutes. Maria, do you want to drop the survey in the chat for everybody? I really need everybody to please do the evaluation survey. We need to use that for our reporting, and it's kind of what we write our activities around. So if everybody could just click on that survey link that Maria just put into the chat, I'll give you a minute or two to do that.
And then I
We
saw
have-
Dylan asked something about something along the same lines for colon cancer or breast cancer, like when we have open orders. Is that, Dylan, are you referring to like the open lab orders measure and trying to see when you have ordered colonoscopies and mammograms?
Kind of like an adjusted rate, I think would be helpful. So like kind of like to see like we've done our part and make
Yeah.
sure that like it's documented there. And because like it's good to have measures that are like what it is, like what is the measure as like HRSA wants to see it, but then also on our workflow side of we did the things that we could do and it's up to the patient at this point. So having
Yes.
those kind of breakouts is helpful. Like some of the yeah.
Yeah, I have been, this is a like a pet project of mine. I've been trying to push this through internally for a while now to have something like that in the detail list of the column where you could, in the column detail list where you could easily identify, okay, who has this already been ordered for? Because it's a very
Mhm.
different workflow, right? Whether you're following up on something that's been ordered or you're trying to get a patient in for the first time to close that care gap, right? Like we understand that. We don't have anything right now, but I do think that we're looking into how to what kind of functionality we will build around that. In the meantime, we do have the open lab orders measure. Again, it's not all encompassing. Um, Obviously, this is more restricted to labs, but I know what you're asking for. We don't have anything like that. This is the closest we have, which is open lab orders.
Do we have any lingering questions from anybody?
Hey Dylan, did you want to post the question about the registration and the Hilo check-in and having too many race ethnicity options to pick from in oh gosh, on our website in the
Yeah,
it's
I
not a
believe
form.
I did. It's in there.
Excellent.
Yep.
So if anyone else is having trouble with doing Hilo check-in registration and finding that there are way more options to pick from for race and ethnicity than they intended, um, please interact with Dylan on our website.
We also have a race and ethnicity grouper. I don't know. I'm not sure what this is all related to. And I don't know if this would be helpful information to share. But if you in your raw values, um, mm, sorry, if in your raw values, for example, you have like very granular things that don't report up into your UDS values, um, you could also create groups. Like, you have to map everything right to your UDS values in your mapping admin in the the race section. But if you wanted to do like quality improvement and you wanted to have more granular categories, if that's what you're collecting, you could create groups similar to provider group and payer group, where you could create your own groups of race, ethnicity, or language.
Do it would I was thinking about that. It would be kind of helpful for both like the groups and the providers if there was like a not function. So we could select all the groups that are valid and say if they're not in the valid groups, then put them in a group that we could audit.
Mm.
Similar with
I
the
mean,
providers of like these are all the outside providers that we're not gonna really.
yeah, that is good. But when you go to mapping and you go to race, that kind of happens because that will come in as unmapped.
Yeah.
Right now, like that's how I know what you're asking, but like we kind of do that with the unmapped right now. And then anything that wouldn't fall into these, you would have to like choose ignore or your archive.
Yeah.
Yeah. Or I think it's just ignore on this one. I don't think you can archive. But yeah, that second option that you just mentioned would be even better. And kind of how we're trying to build the product out, right? More in kind of giving you those insights and saying like, hey, these are the things that you need to look into instead of having to come and figure out what you need to look into. So that's like we're going to be building more AI capabilities within Drives to help elicit or highlight those key things versus like having you come in and look at certain things and remember to do it to find it. Like it'll be more of like a proactive, like, hey, did you know all these race things are coming in an unmapped bucket, or like we don't know where to put them, and it would alert you. But we're still a little bit of ways out. We're just starting to develop that kind of stuff.
Well, thank you, everybody, and thank you for filling out the survey. I appreciate you doing that. If you have any follow-up thoughts or questions, be sure and let me know. And have a very happy holiday week, and I will talk to you again soon.
Thank you. Bye.
Thank
Thank
you.
you, everyone. Bye.